From a leadership standpoint, I say sit down, take time for those patients, and just say, are you doing okay? And tell them it's okay to not be okay.
Hello, this is Zach with the American Journal of Healthcare Strategy, and you are listening to the Clinicians in Leadership podcast, where we focus on empowering clinicians from bedside to boardroom. Today, I am joined by Dr. Allison DiPasquale. Dr. DiPasquale, why don't you take a second to introduce yourself? Tell us a little bit about your experience and your current role and how you got to where you are today.
Well, thank you so much, Zach, for having me, first off. I'm Dr. Allison DiPasquale, and I am a breast cancer surgeon, also known as a breast surgical oncologist. But I like to call myself the quarterback for the patients because my role is in leadership in the hospital. I run out of Dallas, Texas, and I run our multidisciplinary tumor board, as well as I am medical director of breast oncology. So, in a lot of different hats, as well as being the surgeon, my goal with a patient is to give them the best technology, to give them the best care, to give them bespoke healthcare based off of their specific type of cancer. Not everyone's cancer is the same. And I run a lot of technology or help a lot of technology companies just move that needle forward of how we can do our healthcare better for women. And so I'm super excited to talk to you today about life after cancer and where we're going with things because there's a lot out there.
Well, and Dr. DiPasquale, we're grateful for you wanting to come on the show and to just share some of those experience and insights as well. And I'm excited to dive into the different hats that you wear and the way that you quarterback those hats well. And so, but before we get into that, I know that you have a bit of history with breast cancer in your family, and that helped shape not just who you are today, but decisions and approaches to your career that you've made. Can you tell us a little bit about those early experiences and how that influenced your approach to patient care as well as leadership?
Yeah, sure. No, so I mean, I've always called myself an early decision maker. So there's no doctors in my family. I come from a very tiny town in Wisconsin, 34 people in my graduating class, so very small. And at the age of 3, I used to watch a show about the human body, which is called Slim Good Body. It was on after Sesame Street. And I watched the show and was like, oh my gosh, this is amazing. Like it showed to blow apart how the blood moves. And I was like, sign me up. I'm going to be a doctor. And I remember my family being like, okay, you're from this tiny town. And really, that doesn't, but I just knew it was born in me. And then I knew I wanted to be a surgeon when I got into sewing. And so inside me was to help patients. And how can I do that? And using my hands, I knew from an early age was what I needed. So when I got more focused into my career in medical school, there has been lots of cancer in my family, including close relatives with breast cancer, brain cancer, pancreatic cancer. And I started saying, wow, this is the care that's happening. How can we do this better? So as an early decider and intern in surgery residency, I remember just doing gallbladders and hernias, and these patients would come in, I'd never see them again. And then I went to the breast clinic, and my mentor gave every patient a hug. She knew where their children went to college. She followed them yearly for their mammograms. They were her family. And so early decider, going into breast surgery. And also my family had been pretty affected by that. So for me, it was not only doing this, have a patient connection, but how can I keep working to make technology better? So again, intern and residency decided, and then went on for my fellowship and really asked the question, why? Why are we doing it this way? How can we do it better? Which then led me to, open up with different technology companies and help with leadership roles of really, we need to rethink women's healthcare. Why women just show up and say, I've got cancer, take it out. I don't care about anything else. I don't care what I look like. I don't care anything else happens. I have a family and I need to go home to them. So get rid of it. But now we know it's not that urgent. It is urgent, but we have technology, we have medicines, we have new surgery techniques to make you look beautiful, feel beautiful. and not only give you life, but give you life after cancer.
I'm excited to dive more into that life after cancer, and how improvements in technology and just approaches to by your clinicians and your leaders can have a bigger influence in the quality of life that a patient experiences after that cancer and surgery to remove that cancer and the treatments. And I think that's such a big thing. But regardless, cancer is a very prevalent disease within the world today, and it's a very scary thing. That's a scary word. And that, I think, hearing you talk about the opportunity with working as a part of the breast cancer team to have a relationship with those patients, and to follow up with those patients, the comfort that must provide to your patients is phenomenal. And the ways that you can then influence and have an impact on their life post cancer is got to be critical. And so I'm curious though. We'll get into that a little bit later on, but one of the things that I've loved, I've heard you describe Surgery Day as Cancer-Free Day, and I think that is such just an incredible way to describe it. It's this moment, the surgical day of closure, of new beginnings with patients and for those patients. And so, how does describing Surgery Day as Cancer-Free Day affect the care that you provide, the care environment that you create, and the emotional experience that those patients experience?
Well, I think it's important because patients say, well, when am I actually cancer free? And if you ask a surgeon, it's the surgery date, right? If you ask a radiation oncologist, it's when they finish radiation. And if you ask a medical oncologist, it's when they finish their, 10 or 5 years of tamoxifen or whatever they're on, right? But truthfully, the removal of the cancer happens during surgery. I'm not just biased, that's what we're doing. And whether it's residual cells because they've had such great treatment from my partners, and that's why we're multidisciplinary, that's great, or whether it's a tumor. But I do think that patients need to know that there is a light at the end of the tunnel. And that when they show up on their surgery date, I give them all a big hug and I say, welcome to your cancer-free day. We add in bonus lifted ladies day if we're doing a little lift, flat tummy day. We add all these little silver linings that would have never been included and covered under their insurance into their cancer-free day. And so we make it more of a empowering moment for women, because surgery of your womanhood when you're sleeping is scary.
Yeah.
And we are now taking that scare and saying, this is empowering. This is you taking care of yourself. And this is you crossing that finish line. Let's do it. And so it's just kind of an emotional moment. And my patients I have a connection with them on that.
Well, and I love shifting that dynamic from cancer, which is inevitably feels out of our control and is scary, to getting to that surgical day and being and feeling empowered, has got to be just such an incredible shift in emotions and experience for those patients. And so then surgery is complete, Cancer-Free Day, and an incredible experience there. However, I want to talk a little bit about this concept that you've introduced called Livingship, and just how you are intentional in focusing on how you can help your patients thrive, not just survive after breast cancer treatment. And so, but
Yeah.
before we get into a little bit of Livingship, and just talking through that and how that affects your approach to care, but also leadership and decisions that are made. Can you just walk us through what Livingship is? Because that I don't think that's a word that maybe
Yeah.
a ton of us are familiar with.
Well, it's one of my quote DiPasqualeism. I have a lot of words that just kind of flow out because I think they make sense, and I think that they're relatable and it makes sense to a patient, because I think that when you're cancer free, right, you do your surgery, you do your medication, you do everything you're supposed to do, and then you're just survivorship. That sounds miserable. You shouldn't be surviving. You beat something. You're empowered. You did this, and I always say you should be living, period, cancer free, not just surviving. So instead of calling thrivers or whatnot, we just call it livingship. You are just in this livingship period where maybe you find a new heightened version of yourself throughout this
Mhm.
process. This is not a sprint. This is a marathon, breast cancer journey. It is. Find different changes in patients' lives, who's in their life, who's not in their life anymore. But it's this journey, and this is the celebration at the end of how they're living, and their new sense of self should be celebrated. So that's the big focus for me, is how do we minimize all the other potential side effects or problems from the surgery, from the radiation, from the, chemotherapy if they needed it, or endocrine therapy, and make them living cancer free, not just surviving.
Well, I can't imagine that what the effects of that has on one, just that clinician patient relationship, showing that you care beyond what simply just what your job is to treat the cancer. You're showing you care beyond that, and you want to help them not just survive but thrive. And so going off of that, this concept of livingship, it seems powerful. So how does this concept, or this philosophy is a better word, I think,
Mm-hmm.
change the way that clinicians should approach long-term care for their patients? And then it's kind of a secondary question to that. How can leaders of these multidisciplinary teams and leaders of healthcare organizations champion this philosophy? Because it really is going an extra mile to provide that extra empowerment and that
Mm-hmm.
extra step to make sure that your patients have that quality of life that they deserve. And so, how can first, I guess, first question, how can clinicians, how does this change their approach to long term care? And then secondly, how can the leaders of those clinics and disciplinary teams champion this philosophy amongst their teams?
Well, I think the first thing that clinicians need to do is be honest with the side effects. I think upfront honesty of potential side effects of the medicines, the surgery, the radiation, whatever we do needs to be discussed up front so patients have full understanding of what they could be. And then how we're going to mitigate that. Hey, this could happen, but these are the ways that we're going to fix it. So for me, it's all about honesty. I think that one of the things that's not touched on a lot is lymphedema. We say, oh, as surgeons, we operate, you're cancer free, you do your radiation, we follow your mammograms, and we love you and we take care of you. But if anything would happen to that arm, oops, that's just part of surgery. But being upfront to my patients, saying these are the side effects, these are the risks of what I'm doing, but this is the technology I'm going to use to prevent it or find it early when it's treatable and curable. And so that's really where I got into this big lymphedema program. So, working with the leadership here, really being a champion of that and saying, I don't care if insurance doesn't cover it. In the beginning, they didn't cover at all this machine that I've been using for years. And I said, it doesn't matter to me. I will take the hit because this is what's right for patients.
Mm.
Now, fast forward 5 years, it's now in the NCCN guidelines, which is the governing cancer consortium over what we should be doing to follow patients. So lymphedema is a problem. It can happen from chemotherapy, taxane based,
Mm.
radiation, and definitely surgery. Even one lymph node being removed. People are like, oh, I've only had one lymph node removed. I'm fine. But that's not true, because if that incision is really big incision, you've dissected through a lot of lymphatics to get that one lymph node versus taking out 10. So for me, really championing and keeping on a screening lymphedema program to prevent it, because lymphedema is something, again, it's like the dirty secret. No one wants to talk about it. And when it happens, everyone wants to pass the buck. Oh, it was from here. It was from the radiation. Oh, it was from this. No one takes ownership. So for me, it's about upfront, discussion with patient, taking ownership of what we do to patients, how we mitigate it, and finding it early to treat and cure it so they don't have symptoms moving forward and they really can live, not survive.
Well, and I love, and I think you provided a very tangible example on just the importance of clinicians advocating for their patients. When you talk about, 5 years ago implementing this treatment and using this machine, not covered by insurance, not necessarily within guidelines, but you knew it was better for the patients and that it would improve the patient's quality of life and improve outcomes. To fast forward now, it is part of the guidelines, and it is covered by insurance, and just that doesn't happen without you advocating and insisting on it, and as well as there's countless, that's how innovation happens, and that's how guidelines are, and insurance are changed for the better, is by having your clinicians who have the patient centered perspective and understand the patients and know what's best for the patients, a part of that decision making process, and a part of that innovation process. And so I'm excited to talk a little bit more about that just a little bit later. But before we get into that, there's one more thing I want to talk about, just this concept of livingship. But it's it's the balancing act of the technical aspects of treatment with the emotional and psychological needs that patients have. So the technical side, which is the actual treatment, as well as the going beyond that and providing that emotional and psychological needs that those patients have, and to encourage thriving. So how can clinicians better balance the technical treatment side, which is needed, but also incorporate that concept of livingship, that philosophy that I love that you talked about, to help their patients thrive by also addressing their emotional and psychological needs?
I think just sit down,
Mm,
listen, ask your patients the questions. They're not going to tell you if you don't ask.
yeah.
And so, I mean, obviously, lymphedema is something we could see or measure, but like with the side effects of having potentially a mastectomy, what does that mean in terms of maybe their culture or their sexuality or all of the different side effects that can occur downstream from the endocrine therapy? Um, they're not going to just upfront tell you. You have to ask. And so, from a clinician standpoint, from a leadership standpoint, I say sit down, take
Mhm.
time for those patients, and just say, "Are you doing okay?" And tell them it's okay to not be okay. So that allows and it opens that moment to say, you know what, this is happening. And I'm not enjoying this with my husband, or I feel self conscious about this, or it just allows that moment for them to get it out. And that allows them to, for you as a clinician, to now help guide them down different technologies or different areas that potentially can help them.
Well, and I would imagine also that that opens up that dialogue and builds trust within that relationship, so that down the line, if there's a different side effect that is hindering them, or there's something else that comes up, they know they can come to you and talk to you about it because you've
Mhm.
already established that you care about them, and that it is a safe spot for you, and that it is okay for them not to be okay. And I think that's critical. And I love how that is something that anybody can do, is just to ask the question,
Just
ask the
ask.
patients. You're not implementing a brand new initiative or implementing a new program. It's simply just sitting down and having a conversation, human to human. And I think that's phenomenal, and just the impact that that makes is phenomenal. So moving on a little bit, I want to talk about advances in research and technology, and how the just I mean we're artificial intelligence. There's a wealth of technological advances that are uh, you know being championed as the next big thing, and the thing that's going to improve lives, improve staff experience, and change patient care. How do the clinician leaders, how can those clinician leaders bridge the gap between research advancements and then the practical application of everyday patient care? Because often what's newest is maybe not the most practical for what we need it and what is helpful now. So how can leaders balance and bridge that gap between recognizing which technologies to introduce, and research advances to pursue, as well as just what works? How do you figure that out?
Well, I think, for me, especially dealing with a hospital leadership position, it's all, we have to be cognizant of our funding, right? And our funds and using healthcare funds. But for the right purposes, it can be, we can figure it out. And I always call it ROI, return on investment, right? So we're going to vet the technology. There's going to be, first off, we have to apply an issue. What is the big problem that's happening in women's space? So, what is that problem, number one? Number two, what are the technologies that could fix those problems? Then vet those companies and see what is the actual, preliminary data. What do we have going on here? And then typically for me, I don't just jump into something new and say, okay, I'll try you all. But I do trials of them, just to see what's going on. I do my own research studies. And then I also just do quality studies for patients because if I'm going to do something that's helping them, I need to show that there is actually a quality improvement. So, quality improvement studies are super important as well, for leadership as well, to adopt new technologies. So, I think you have a problem, you have to have technologies, you have to vet them, and I think you've got to prove their worth through your own clinical trials and quality improvement.
Dr. DiPasquale, I'm grateful for your time today, and just your insights and your experience and getting to share this, and particularly the grateful for the way that you've championed Livingship and helping your patients thrive and not just survive, but to thrive. And just encouraging to me to hear the passion and the heart behind that philosophy and the way that that's being implemented. So, but before I go, and before I let you go, there's just one final question. So we've talked about Livingship. We've talked about bridging the gap between technology and what's practical and what can be applied. We've talked about helping patients thrive, not just survive. So in all of these things, what are some strategies that you use to inspire and empower your team to prioritize the patient and prioritize innovations that prioritize the patient? And how do you promote that buy-in? Because change is inevitably hard always, and especially when you're dealing in the field of cancer and breast cancer, it's especially scary because there's a lot of change that's happening. So how do you promote and encourage the patient to remain at the center of all that you do?
Well, I think I only keep good company. I
Mm,
always say only kind people here in my office. The motto to my office is patients first.
yeah.
I love you all. You're all my family. All my staff is my family. But the patients always come first. So that is one of the prerequisites. And again, if you're just here for a paycheck or whatnot, that's not what I need. I need somebody. I've got the best staff ever right now. I've got my Care Bear. We call her Care Bear because she cares so much. I have my workhorse, my right hand, who's going to get it done. I've got my nurse. So we've just got this good team. But I think it's trial and error. You don't know right away in terms of staffing or even in a hospital setting. In leadership, who's going to be the champion. So I think for me, as the leader of my office, is I have to say, patients first, they know. We also have a meeting every Friday afternoons after all the patients leave, where we just talk. What could we have done better?
Mm.
What could we have done? What did we do right? um, and sometimes, maybe when all the patients are gone, we have a little champagne called Champagne Fridays. But for those who drink, and we also have non-alcoholic. But we just make it fun environment for the people in my office to really say we are here for the patients. They don't
Right.
work for me; they work for the patients, and so that's really what we have to talk about in our office. And I give them the room and the space to complain to me, their boss, about things that could be better or things that did go right. And so
Mm.
give them that space as well, so they feel like they're in control. And again, they're not just coming in for a paycheck; they're here for the patient.
Well, and I love that. I love that open communication, as well as just the constant feedback and improvement in areas for where you can improve. Because especially in healthcare, if we're not constantly evaluating and for areas that we can improve, we're falling behind in some way. And so it sounds like to be a member of your team is a pretty fun spot to work. And so thank you so much, Dr. DiPasquale. We're grateful for your time today, and for your willingness to come and to talk about Livingship and your experience and the way that you and your team have helped change and save lives. And so we're grateful for your time today, and wish you the best going forward.
Thank you, Zach. See you later.